I'm Anna Christofides, the Program Director for the CHCG and President of IMPACT Medicom, which provides project management, editorial support, and coordination of consensus activities. The Canadian Hematology Consensus Group, or the CHCG, is a national collaboration of Canadian hematologists and healthcare professionals dedicated to improving patient care through the development of national consensus recommendations in hematologic malignancies. The goal of the CHCG is to develop timely, practical, evidence-informed recommendations that support clinical decision-making across Canada in rapidly developing areas of hematology. Today, we'll discuss the vision and structure of the CHCG, as well as key unmet needs in lymphoma and leukemia that are being addressed through current and future consensus initiatives. I'm pleased today to be joined by Dr. Carolyn Owen. Dr. Owen is an associate professor in the Division of Hematology and Hematological Malignancies at the University of Calgary and a hematologist at the Tom Baker Cancer Centre. Welcome, Dr. Owen.
Thank you.
So I guess that we could start off with what led to the creation of the CHCG. What was the reasoning behind it and the unmet needs that it tries to address?
So I think the big issue in Canada is a lack of sort of cohesion necessarily between provinces, maybe because of provincial healthcare funding, and often different approaches to the management of the same diseases, especially when funding isn't necessarily the same in all provinces, but a desire to really be more equitable and for everybody to be approaching these lymphomas in the same way. So historically, I had worked on CLL guidelines, and I was being approached repeatedly by my colleagues and by industry partners asking me when I was going to produce a new updated set of guidelines. Because what we came to realize is that when you do this and you create sort of consensus recommendations, that they quickly become out of date when new data is published, especially in lymphoma, where there's been so much progress in the last several years. So I thought it was a great idea for us to have these kind of consensus recommendations with involvement from people across the country, but I didn't have the energy or maybe the time to be able to be taking that on independently. So we thought that if we had a group of people who are motivated to do this, that we would be able to share the workload and that we would be able to really represent national opinions and review the evidence in a high quality manner in order to be able to provide guidance for clinicians who are treating these patients and for funders. We can influence possibly our provinces or the CDA in their approach to funding therapies if, as a consensus, we all agree that certain therapies should be prioritized.
Thank you. That's great. And why is it that national consensus building is becoming increasingly important in rapidly evolving diseases like lymphoma and leukemia?
I think that the biggest issue, especially for lymphoma, is that there are so many new therapies being approved and with good quality data to support them. But what happens is therapy A is compared against therapy B, and one is the winner. And at the same time, therapy C is being compared against therapy D, or even against A or B again. But we end up with multiple therapies with good evidence, but they're not compared against each other. And it makes it very difficult for clinicians who are treating multiple different diseases to stay on top of the data when there's now multiple therapy options for an individual patient without comparisons between them. So having expert consensus helps clinicians and helps patients know sort of a perspective on how to approach all of this data. Sometimes our opinions are going to be that both therapies are completely reasonable and that we don't have a preference for one or the other. But sometimes if there isn't a comparison, there might still be a preference for one over the other. And I think that having national opinions on that is very helpful for clinicians who are offering therapies to their patients.
Great. And just looking at the structure of the CHCG, how is it structured and what are the various parts of the CHCG and their roles?
The most important thing that we wanted to do was to try to represent the country and to try to get a hematologist with lymphoma expertise from every province or at least every region. And we wanted them to be relatively equivalently represented so that we're not just providing recommendations, let's say, that come out of Alberta, because that's where I live. And so the goal was to try to involve as many people as possible while maintaining a group that's not so large that we can't actually sort of complete tasks because everybody obviously has to be committed to the project. So different people also have different areas of subspecialty interest. Have an interest in CLL. Some people only treat certain kinds of lymphomas and they don't treat others. And so our hope was to have people who have a special interest in that disease be more actively engaged in that recommendation publication and maybe have more of a broad involvement for the disease sites that they are maybe less subspecialty focused in. So we're trying to get scientific expertise, we're trying to get treatment experienced people, and we're trying to get representation from across the country.
That's great. And how do you handle it when members of the committee are not necessarily specialists in a specific area that we're focusing on?
Yes, so the members of the committee don't have to participate in terms of the fine detail of every one of the guidelines. The goals of the committee were to ensure that we addressed the appropriate topics in the appropriate order. It's very difficult. We could really be trying to develop recommendation guidelines for every different disease within lymphoma, which we all know for non-Hodgkin lymphoma is hundreds of different subtypes of diseases. Certain diseases I would say, are more complex in terms of more recently developed therapies, less certainty as to how to approach the new therapies, where individual physicians would take greater value out of having some direction. So for example, we've started with relapsed refractory follicular lymphoma because there have been so many new therapies in that area. And historically, we didn't really have almost anything specifically funded for relapsed refractory follicular lymphoma. In comparison, there were guidelines developed for follicular lymphoma in first line almost a decade ago. And really our approach in Canada is very consistent. And there's not a lot of debate about how to approach first-line follicular lymphoma. So clearly a new guideline for frontline follicular lymphoma treatment is not higher on our priority list. And yet we started with something we thought would be most valuable.
So why don't you talk a little bit about those topics and also the role of the other aspects of CHCG, like how support is provided and so on.
The first topic, as I mentioned, that we're working on is relapsed refractory follicular lymphoma. And after this, our goals are to address frontline diffuse large B-cell lymphoma, because there's been lots of movement there. We will try to update both frontline and relapsed refractory CLL approaches soon. As I said, there's been a lot of change since those publications, despite them being actually more recent than some other Canadian papers. There is also, I think, a strong desire to address mantle cell lymphoma, both frontline and relapsed refractory. And this is sort of the feedback we've had from all of our participants. So IMPACT Medicom is helping us with medical writing, with collating the evidence into a structured format where everybody can review the data. We should all know the data, but sometimes you don't know all of the nuances. And in terms of helping to address specific questions, we then have created almost a survey format where the participants have to agree to the final statement of recommendation or suggest alterations to the wording if they prefer something different. We're using this Delphi format, which is ensuring that there is clear agreement between all of the group, and it's not just sort of one person's opinion and other people saying, sure, close enough. And so we have involvement of the individual authors in terms of developing the statements. And then after we have our recommendations developed, we're asking a larger number of lymphoma specialists across the country to provide their feedback as to whether they agree with our final recommendations so that we can be confident that we're really representing a national opinion.
Mm-hmm. How is that different from what's been done in the past in Canada?
I think historically, most kind of recommendations or sort of guidelines that have been produced in Canada have been maybe a collection of authors who have an interest, writing really a review of the data and providing a sort of high-level overview of funded therapies and maybe some pros and cons of each, but without such clear direction as to, more strongly recommend or less strongly recommend, and certainly not this sort of Delphi surveys and less individual clinicians involved in the process. And then obviously the involvement of the medical writers, it depends on the individual sort of guideline that's been produced in the past to how much detail there has been. It really depends how much effort you put into it to how much detail is involved.
Makes sense. Just looking in a little bit at the individual topics. So, starting with follicular lymphoma, and you mentioned that the need is more in the relapse setting. What are some of those unmet needs, and what is the paper addressing?
So for follicular lymphoma, as I mentioned, we actually didn't have any specific therapies funded in Canada for relapsed follicular lymphoma. And then more recently, there have been a number of clinical trials, and CAR T cell therapy has been funded. There's a number of therapies that are at the CDA today being considered for recommendations on funding for relapsed refractory follicular lymphoma. So I think that within the next year, there's going to be multiple therapeutic options where previously there were almost none. Previously, we were using chemotherapies repeatedly. Some people were doing autologous stem cell transplant. There was just a lot of variability. So we wanted to address all of those new therapies for which there's evidence. So lenalidomide and rituximab with epcoritamab or tafasitamab, the bispecific antibodies as monotherapy, the CAR T cell third-line therapy. So we wanted to address all of those therapies, and I guess zanubrutinib and obinutuzumab as well. We wanted to provide some sort of high-level direction about the fact that it's okay to watch patients who don't meet treatment requirements at relapse, the same as is quite standard for first-line treatment of follicular lymphoma. And then some maybe classifications to the approach of the therapy based on early progressions versus late progressions, so more kind of treatment-resistant patients compared to those with later relapses.
Great. And then looking now at DLBCL, if you can talk a little bit about what that paper would address as well.
Yeah, so the first-line diffuse large B-cell lymphoma paper, it kind of seems like not very long ago that would have been a very simple topic. I mean, everybody got R-CHOP, but now that polatuzumab vedotin in combination with R-CHP is funded in most provinces for patients with either non-GCB diffuse large B-cell lymphoma by immunohistochemistry, or ideally with time they will develop the actual cell of origin proper testing and be treating only those with activated B-cell type. So that's a big decision maker for advanced stage patients for R-CHOP versus Pola-R-CHP. Then there's the question about which patients with limited stage disease can get abbreviated therapy, actually, less treatment. There's questions about who should maybe not be getting full doses of therapy, and the approach to sort of frailer or older patients. We do want to address prophylaxis against CNS disease, because that's been a high level of debate for years. And the data is increasingly clear that although CNS progressions are a really bad thing, that trying to prevent them, we probably really haven't figured out how to do so yet. And then some addressing of PET scanning within therapy and use of interim PET scans to alter therapy. Some people are considering that, and just to review the data or the strength behind those considerations.
Great. And so I understand those are the topics for 2026. Looking into, future years, what are some of the topics that are on the list, and what are their unmet needs?
Yeah, so I think that the CLL frontline and relapsed refractory updates are of interest to many people, because there's been so many therapies funded in CLL. And as mentioned, we really have an interest in mantle cell lymphoma, because I personally think that's really maybe one of the most complex, with lots, again, of new data, where to place BTK inhibitors, new relapse therapies there. And then we also know that there's a lot of different options for relapse refractory diffuse large B-cell lymphoma with CAR T-cell bispecifics, bispecifics in combination or as monotherapy. So those are some of the really big topics that are planned for coming later.
That's great. And so with all of these outputs from the CHCG, how do you hope it can help the lymphoma and leukemia community as well as patients?
I mean, I think it's obviously helpful to patients when there is a sort of equitable access to therapy in the country. And so having consensus recommendations to follow a certain treatment approach gives clinicians in different provinces the ability to argue to their funding if they don't have that therapy easily accessible. I think it also helps clinicians who are, very busy in practice, especially those who treat a whole bunch of different diseases, to stay up to date in a sort of simple way to review the data, because all of the references are there as well. So I think that's helpful for oncologists who treat lots of different diseases. It's really hard to stay up to date on every individual subtype of lymphoma when there's been so much progress recently. And I think that it helps patients to know that we are working together as a group, and that difficult cases. You're not the first patient who's had a difficult case, and that we, as a group of clinicians across the country, we do work together and we do try to help each other. And so you're getting an opinion that is more than just the one doctor you happen to be referred to, but a broader opinion from many experts across the country.
That's great. And how do you think that could help patient equity, in terms of access to these options?
So as I mentioned, I think it helps with within different provinces for sort of leaders in the field to ensure that access is requested. But for individual patients, it helps prevent the possibility that somebody who maybe didn't see the presentation last year at ASH and hasn't really heard about this other therapy yet, that maybe something gets missed. If you've got national consensus guidelines, the patient themselves is able to read those. If they're published, they can advocate for themselves, but also their busy doctor will have been able to sort of see how the Canadian approach is recommended and follow expert guidance from others. It really reduces the chance that an individual patient might get a sort of therapy that was considered standard 5 years ago, but maybe isn't anymore.
That's great. And so, for you personally, Dr. Owen, I was wondering, as the chair of the scientific committee, what makes this initiative meaningful to you?
I mean, I really like working with my colleagues from across the country. I think it's very interesting how different regions can have different approaches to some therapies when there is true clinical equipoise, when there's sort of a complete uncertainty as to what is the best therapy. It can be really enlightening to talk to different people and to hear their perspective. Sometimes it seems obvious to me that X should be better than Y. And when somebody tells me that they think the reverse and they explain it, I recognize a perspective I might not have saw before. So I think that there's real value in that. But also I think that as national leader, as sort of a more senior lymphoma treater in the country, it is, I feel, incumbent upon us within academic roles to help those who are, more broad in their practice, to help people with our expertise to make it easier for the average oncologist to decide how to treat complex patients when there's so many new therapies being developed and funded every year.
That's great. And I know for myself, it's so exciting to be part of this, and, just to feel that, we can provide some support in terms of this process. And so I'm very excited to see it growing and, maybe filling an unmet need in the hematology community. So yeah, with that, I just wanted to draw listeners' attention to the website of the Canadian Consensus Group. So it's www.canadianconsensusgroup.com if you'd like to look there for more information. And I also wanted to thank our funders. So for the 2026 papers, Roche, B1 Medicine, and Insight have provided funding for us to be able to develop these, and also for Merck Canada for funding this video capsule. So with that, I just wanted to say thanks so much, Dr. Owen, for your time, and looking forward to working with you in the future on this.
Thank you very much.